Hi, everyone. Thanks so much for coming today. Dr. Kamdar and I are so excited to be here and are really looking forward to this discussion. Please feel free to type whatever questions you may have thought of related to the presentations or anything else into the chat box. And we will try to get to as many questions as we can. And I think we'll start maybe just with a few of the questions that have already been submitted. So one of the first questions relates to the ponatinib blinatumomab study. And the question is specifically referring to the patients in the study who had blast crisis CML and whether they all had T315I mutations. So this study is an exciting study. It's looking at the combination of ponatinib and blinatumomab for Ph-positive ALL, both frontline and relapsed refractory disease. But it also included patients with blast phase CML who were in lymphoid blast crisis. So this study did not require that all patients have the T315I mutation to enter. So the reason, so ponatinib, of all the TKIs for Ph-positive ALL and CML, ponatinib is the only TKI that is effective against the T315I mutation. Ponatinib is also very potent, very selective, and effective against almost all other single point mutations in BCR-ABL as well. And there'd been a previous study looking at dasatinib plus blinatumomab combination, which had looked great. But in a lot of the studies with Ph-positive disease, a common mechanism of relapse is secondary BCR-ABL mutations, including T315I. And so that's why they looked at ponatinib in this study, but patients were not required to have any specific mutations to enter. So thanks for the question. And then it looks like Dr. Kamdar has a couple questions as well.
Great, thank you so much. And I think we have a couple of questions here. The first question is ACALA now recognized as a first line by the NCCN? The answer is yes. That's based on the Elevate-TN study that acalabrutinib is now listed as one of the frontline regimens that one can consider for patients with treatment-naive CLL. And then the second question is, what is your preferred regimen for frontline CLL, 17P or not, after ASCO? So I think at ASCO, we clearly had a couple of updates. We had the Elevate-RR study, we had the Elevate-TN study update, and then we had some excellent results that were presented from the Captivate study. However, I think the Captivate study needs a little bit of a longer follow-up. I don't think it's ready for prime time yet. And I think the most important study that we are all waiting for is the CLL-17 study to really address which should be the preferred line of therapy. For example, should it be a BTK inhibitor indefinitely versus venetoclax plus obinutuzumab, or should it be a BTK inhibitor plus venetoclax in a time-limited fashion? However, until more follow-up is presented, for me in my clinic, in patients who are 17P or TP53 mutated, my preference remains a BTK inhibitor. And that's based on data. For example, based on some of the long-term follow-up data that was presented with ibrutinib, as well as the Elevate-TN study, patients who do harbor high-risk cytogenetics, they continue to do well. On the other hand, if you look at the CLL-14 study, and when they parse out patients who have 17P versus not, there is a clear dip in the PFS. By that, I don't think it means you cannot use that regimen, but I think if someone does really want a time-limited treatment, I think it's okay. But my preference for high-risk cytogenetics like 17P and TP53 would be BTK inhibitor indefinitely. So I hope that answers your question. We are still looking for more questions, so please keep them coming. We have one question for Dr. McMahon. So based on the positive findings of including palliative care in your study patients' plan of care, do you anticipate incorporating palliative care in general practice?
So that's a great question, and it's a very important question. And this study that looked at incorporating palliative care early in the treatment course for AML patients getting intensive therapy showed some very exciting improvements in things like depression, anxiety, PTSD symptoms, quality of life. In this particular study, so patients had been randomized to either kind of standard of care, and the primary team or primary physician could consult palliative care if needed, versus early upfront palliative care consults. It did involve kind of specialty palliative care consults. And I think, what clearly it's really important. And I do think that as part of our oncology practice and training, I think we really need to, improve incorporating those aspects into our care of patients. I'm very excited about another palliative care AML study, which is being planned by the same group led by Tom LeBlanc at Duke and Dr. Al-Jawari at MGH and colleagues. They're actually planning a study to look at early incorporation of palliative care for AML patients getting intensive chemotherapy, and they're going to be comparing outcomes for patients who are actually seen by a palliative care specialist versus just training the patient's oncologists in better palliative care. And so I'm really excited about that one because this is a really important topic. So thanks for the question. And it looks like Dr. Kamdar has a question. Has anyone done cost analysis looking at the options in lymphoma, including CAR T, bispecific antibodies, et cetera?
I think that's a great question because that's what we will be heading towards, especially with such excellent data that we now have with CAR T cell therapy, long-term follow-up. If you call 4 years long-term follow-up, at least 40% of patients who would have otherwise universally succumbed to the disease are being salvaged by CAR T. On the other hand, with bispecific agents, we are beginning to see some really excellent signals, even in patients who fail CAR T cell therapy. I'm not quite aware of any specific cost analysis that has been done amongst all the options that are currently available, including CAR T as well as bispecific agents. I think the sequencing of these agents is something that is going to be a question that will be coming to the forefront very soon as we get more follow-up data for bispecific agents. Both of these immunotherapeutics definitely have their pros and cons. With CAR T, it's a one and done, but the economic toxicity is fairly high. It is logistically definitely resource draining, but if patients get into the CR of 45 to 50%, then looks like they're really good. On the other hand, with bispecifics, some bispecifics are given for a time-limited duration. Some bispecifics are given indefinitely. So overall, does the cost build up for it? So I think these are some of the questions that will absolutely need to be answered in the research arena. So at this point in time, I would have to say, we'll just have to wait. And there was a follow-up question to that which said, all these therapies are not curing like an allogeneic stem cell transplant. I think to use the word cure is probably a little more, it's early right now. I think it'll be really nice to see what 5-year, 7-year, 10-year data with CAR T looks like. Not everyone can handle an allo transplant either. But have there been times when patients who have gone through CAR T in the high-risk setting, me or some of my colleagues, have we recommended an allo? In some select scenarios, yes, we have, but I don't think there is a guideline around it. So I think, again, long-term follow-up will finally determine if CAR T or even bispecifics could eventually end up being curative. And I think there was a comment for you, Dr. McMahon. They said that they completely agree with the need for palliative care and onc. Coping is a pillar for better outcome. And overall, they feel like several patients I've encountered are severely depressed when medications are added throughout their care, like levothyroxine or antihypertensives. They feel like they are failing therapy when it isn't failure at all, but maybe more of a failure of setting them up for overall treatment. Any comments on this one comment?
So this is a great question. You raised several really great points, and it's actually a phenomenal study idea. So here at our institution, for any patients who are undergoing allogeneic stem cell transplant, we have a phenomenal psychosocial team with extensive meetings and involvement of both our team, one of our team psychologists, as well as our team social workers, pharmacists, et cetera. The patients meet with all of these people before their transplant and get a lot of counseling as far as what to expect post-transplant. But the question asker makes a great point. Why don't we do this for all of our patients? Why do we wait until a transplant? Because it's definitely true for AML patients and other patients who need intensive chemotherapy. I think during kind of we attempt to kind of set expectations ahead of time, but we definitely currently we don't have any setup for having the same extensive counseling prior to chemotherapy that we do prior to stem cell transplant. So I would definitely love to see us have the ability to incorporate more of these types of discussions pre-therapy for AML. And actually that's a fantastic idea for a study. So thank you for those good ideas.
Great comment and great discussion. So Christine, I'm probably going to ask you a couple of questions as I was listening to your presentation. What's your approach for newly diagnosed high-risk MDS? Should we still be using single agent hypomethylating agents? Should we give them chemotherapy? What is your take on how to approach high-risk MDS?
So that's a great question, and this area is rapidly evolving. So as I think most of this audience knows, single agent hypomethylating agents, either azacitidine or decitabine, have been the standard of care for the treatment of high-risk MDS for a number of years, but this is rapidly changing. So today I showed some pretty exciting data from an early phase study looking at the addition of enasidenib, the IDH2 inhibitor, to azacitidine in patients with high-risk MDS who have an IDH2 mutation, which is only about 10% of MDS patients. And the data looks great. The study's kind of ongoing, so we'll see. But a number of other exciting combinations are also being studied for high-risk MDS. This includes combination azacitidine venetoclax, combination azacitidine pevonedistat, and combination hypomethylating agent with magrolimab, particularly in TP53 mutated AML. Some of the early results from these combinations have looked very exciting, and like response rates are much higher than azacitidine alone. None of these agents are currently approved for the treatment of MDS at this time, and more data is expected, and I'm definitely excited to see the results of the ongoing studies. In my own practice, we are now, based on some of the early phase venetoclax azacitidine data, I am sometimes adding venetoclax first line for high-grade MDS, particularly with patients who have significantly increased blasts, and particularly in those patients who we are trying to get to an allogeneic stem cell transplant, because it seems like adding venetoclax to azacitidine may preliminarily improve response rates and may also lead to faster responses and get patients to transplant sooner. Again, we don't have long-term data here yet, but MDS, particularly high-risk MDS, is a pretty exciting area right now with a lot of new possibilities.
Great. I cannot wait to hear everything that's going to be filling up the arena fairly soon.
Yeah, we're pretty excited. Oh, it looks like Dr. Kamdar got a question. So it looks like the question is, do CAR T-cell therapies, bispecific antibodies, or acalabrutinib in CLL restore normal immunoglobulin production in patients who have pre-existing hypogammaglobulinemia?
Oh, that's a great question. So we do know that with CAR T cell therapy, patients actually have hypogammaglobulinemia. That's just the function of CAR T. That's how it works because it hits on the B cell. As a result, standard practice at most institutions is that in patients who are post-CAR T cell therapy, if they have an IgG of under 400 or whatever is set by the institution, we empirically give them IVIG to prevent them from infections. The other part of this question is even more interesting, which is, does ACALA actually restore the functional hypogammaglobulinemia that CLL can actually set in? And, you know, I think that the thought process is based on some preclinical as well as scientific data is that ACALA does restore normal immunoglobulin production. So usually, as you all know, if people have CLL, which is on watch and wait, one of the indications to start treatment is people who end up with multiple infections. And in those patients, starting BTK inhibition has certainly got them to restoring their hypogammaglobuline levels. And I have seen that in my own practice where the need for IVIG actually keeps going down. With respect to bispecific antibodies, I imagine that they also might end up being hypogammaglobulinemic, but so far the data is scarce and we don't have a huge amount of evidence understanding if they restore normal immunoglobulin function, especially in patients with pre-existing hypogammaglobulinemia.
And I think we only have, it looks like about, I think 2 minutes left. If we don't have other questions, I actually have a really very quick question for Dr. Kamdar relating to CLL. I was just curious what your thoughts are as to whether doublets can be offered outside of clinical trials currently, and are you doing this in your practice?
That's really the burgeoning question right now for most of us. The answer would be no, I'm not doing it outside of a clinical trial, but I am seeking, looking for clinical trials that are exploring doublets, especially in a time-limited fashion. Whenever I see a new treatment-naive CLL patient who needs to start therapy, besides the FDA offered options, I'm also looking for trials for them with the doublets. So I think we are out of time. Thank you everyone for being such a wonderful audience and being so engaged. We love doing this and hope to see you next year. Please visit the exhibit booths during the quick break before the next session. Have a great day.